This webinar is sponsored by the Health Workforce Technical Assistance Center and Montana State University's Center for Interdisciplinary Health Workforce Studies. It is entitled Two States' Experiences Using HRSA's Web-Based Nursing Supply and Demand Model. And it was presented by Linda Lacey, Pamela Lauer, Tim Dall, and Arpita Chattopadhyay on March 22nd, 2017.
Hello, my name is David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. Today's presentation focuses on HRSA's Web-Based Nursing Supply and Demand Model. But before we get started, I'd like to introduce today's speakers and responders. Today's presenters are Linda Lacey, the Director of the Office for Healthcare Workforce Analysis and Planning at the South Carolina AHEC, and Pam Lauer, the Director of the Texas Center for Nursing Workforce Studies. And we are also joined by Arpita Chattopadhyay, the Chief of the Workforce Analysis Branch at the National Center for Health Workforce Studies at HRSA, and Tim Dall, the Managing Director of Life Sciences at IHS Markit. Arpita and Tim will be providing perspective and commentary on today's presentation. Now, at this point in time, I'm going to go ahead and turn the event over to our presenters. Tim, I'm going to turn it over to you.
Great. I'm just going to provide a really brief overview of the web-based model because some of the points others on the panel will go into more detail. But over the past several decades, HRSA has made a commitment to helping state workforce researchers to do their own planning by helping to collect data, by providing technical assistance, and also by providing access to the models, which to date have not been used very much by health researchers, and I'm sure that Linda will explain some of the reasons why. But part of the impetus for this was, goes back to around 2003, when as part of the Colleagues in Caring program, the Robert Wood Johnson Foundation provided money to help states start their own nursing workforce centers. And it became very apparent from discussions with these centers that they were sitting on top of a lot of really good data, but they didn't necessarily have the resources to analyze that data. And so HRSA started making a more conscious effort to make the models, in particular the nursing models, more accessible to those researchers. Linda will briefly explain how she's been kind of at the forefront of using some of these models in Fortran, and we had one in FileMaker Pro and now a web-based one, but different versions of it. And Arpita will also be talking about what some of the goals are, but the issue here is that the states have very good licensure data, much better than is available at the national level by HRSA. And also, there's been critiques in the past about workforce studies in general that come out of the federal government that they happen too infrequently for the needs of the individual states. And so the idea is that if the states have access to the models, then they can update them at their own frequency with their own data, which is presumably more reliable than is available from national sources. And then also the goal that individual states could start to model at the sub-state level to support local planning efforts. The version of the web-based model that we'll be describing today is really focused on supply, and we might call this almost like a trial version of the model in the sense that it was put out there with the goal to get feedback from users, and then based on that feedback, hopefully in the future there will be, improvements and refinements made to it. So with that, I think we turn it over to Linda.
As David said, I'm the Director of the South Carolina Office for Healthcare Workforce. But prior to taking this job, I was the Director of Research at the North Carolina Center for Nursing from 1993 to 2008. And when I went into that job, I searched frantically the first couple of years for some tools that would be helpful in giving us a better understanding of what our nursing workforce looked like in North Carolina. And I became aware of HRSA's nursing supply model at that time. So, and this is kind of a history of my use of these different models. The first request I made to HRSA was back in 1997, and I had to beg for about a year before anyone would consent to sharing the model with me. And quite honestly, I was kind of sorry they did when I saw it. As Tim mentioned, it was a Fortran model, and it had to be run in DOS. Some of you may not even know what DOS is, but before there was Windows, there was DOS. It was a very complex model. It included 24 different data files, and if you wanted to make adjustments to your state-level data, you had to enter all data by hand, cell by cell, and each state was included in this model, so the first thing you had to do was find the row where your state's data started, which involved going through thousands and thousands of rows of data. It just was an ugly thing to use, but on the other hand, I was able to change any of the model elements that I had data that, I could use to inform that. So in many ways, it was a bit more flexible than the current model we have, but I have to say it was just awful to use, and it crashed all the time. It took days to run, even just a simple run. The second model that we made use of in North Carolina was the one that was released in 2005, and that was available to people on 2 disks. It ran in a Windows environment, but it still had 21 different data tables. It was more stable, and it had much better documentation, thanks to Tim Dall, who wrote the technical paper for that model. And it was much easier to isolate your state and to input data. One of the problems, though, with that model was that many of the elements that affect the forecast were based on old data sources. A lot of it came from the national sample of RNs that was done in the 1990s. There were several of them, but still, by 2005, that was old data. The third one, of course, is the most recent model, the one that I believe became available in 2015. Or thereabouts, the online version. And it's totally accessible. Anybody can use it. All you have to do is go online and register. It's very easy to input your baseline information on the number who are licensed. But you can't change many of the model factors that influence how those trends evolve over time to do your projections. All in all, there have been great improvements over the years. I think the fact that the model is now so much easier to get a hold of and to use it's just like night and day. Loading data into the model is also much simpler, and people who have built these models have really thought more about the end user and making things easier for them. And also the documentation about what is in the model, where that data comes from, what the assumptions are, all of that is documented much better than it was in the early years. But there have been some problems. There's not a lot of clarity about when the model elements are, the slide says applied, excuse me, that should say measured, because it's really about understanding how old the data is that is driving some of the assumptions in the model, and I think we could probably hope for a bit more clarity on those things in the future. And also the fact that those adjustment factors currently that are used in the model are sort of permanent, with the exception of the things that you can change in the scenario building part of the model. But things like retirement rates by age or by educational status, those can have a real important impact on that long-range forecast. Same thing with the amount of work effort that you see for RNs by age or by education, or we've even seen some differences by race. Educational upgrades, the loss rates, the in and out migration rates, all of those are things that you might expect would differ from state to state. And right now, they're just sort of blanket assumptions. There are a couple of things where I think are primarily glitches. I don't think they're fatal, but for those of us who actually use these models at the state level and then present results to different types of audiences, these kinds of things make a difference. So in this case, what you see on the left, you see 2 charts here. One is looking at the scenario that looks at what would happen if we changed the number of graduates every year. And we're doing high on the left and low on the right. But the thing that, that bugs me about this is that the axes are different. On the left-hand side, the axes run from 40,000 to 90,000. And on the right, they run from 40,000 to 55,000. And the result is that you get this big visual gap at the baseline that's inconsistent. And again, from a research perspective, this is not really important, but it is very much important if you were to present these particular charts to an audience. There are still a couple of glitches in the model that need to be addressed. This is just some output from a run that we did looking at delayed retirements using South Carolina data. It still baffles me that in the baseline we don't get the number for new entrants or separations or hours worked. Arpita may have an answer for that. On the right-hand side, there's this lovely little box that sort of summarizes the scenario that you're working on, which I think is a great idea. In this case, it tells us that there's delayed retirement is the basis of this scenario, and at the bottom, it's a little more specific. But this is not state-level data. So when it says that there were LPNs added in the first year, that number is the national number. It's not the state number. So little things, but those count. So I would have to say, you know, what is the impact of having state data to put into these models? Well, this chart shows you that for South Carolina, we're using the status quo model here, and the orange line is the data that came with the model, and the blue line is the supply line based on South Carolina data. And you can see the difference is really between having a surplus of nurses and having a shortage. And so I don't think there's any better statement to show you why it's important to have state data to feed into the model. I don't want that to sound like a criticism of the model. The projection models are what they are. And I want to thank HRSA for all of the efforts that they have made to make state-level analysis easier and more accessible. I think what I've learned over the years by using this model is by really working through the nitty-gritty parts of it, all the assumptions, understanding where the data elements are coming from, you become much more aware of the labor force dynamics that influence nursing. And you also become more familiar with the issues that might be different in your state as opposed to what a national model would suggest. I think you always have to question the assumptions and the inputs of any model. It's just the responsible thing to do as a researcher. But you also get an opportunity, I think, to then focus on data development within your state and focus those efforts where they matter the most for the accuracy of your forecasts. So in South Carolina, it turns out that over the years, what has really mattered is the amount of work effort by age. Our nurses here tend to work much more hours per week into their later ages than we see in the national data. And we also have real differences in and out migration rates. My suggestions for future models would be, if at all possible, to permit states to be able to adjust those input factors, like the amount of work effort, or the number or percent of the licensed workforce who is actually working in the state. Educational upgrades, in and out migration rates, all of those things are very important, and ultimately they have a big impact on the end result. So that's my 2 cents. Pam Lauer will go into much more detail about Texas has been able to use their model with their own state data. Thank you.
Thank you, Linda.
Okay, good afternoon, everyone. I'm Pam Lauer from the Texas Center for Nursing Workforce Studies, and I'm going to talk to you about my center's experience using HRSA's web-based model and what we see as the importance of having the state-level data to put into the model. Of course, I don't have the perspective that Linda does of having used the previous models, so just keep that in mind as I go through my slides. Okay, so I'm going to start off by telling you a little bit about our center and the data that we work with, followed by our experience with the HRSA web-based model. And I'm going to do this to put in perspective what kind of resources we have and all the data that we have, and still not being able to put together projections without this model. So we were established in 2004 by the Texas Legislature in response to the nursing shortage, and we're part of the Department of State Health Services. We're governed by an independent entity, the Statewide Health Coordinating Council, and we receive guidance and oversight of our work by a 21-member advisory committee comprised of nurse employers, nurse educators, nurse researchers, a public member, and representatives from organizations that represent nurses. There are 5 staff in our center who focus on the collection and reporting of nursing workforce data as it relates to supply, demand, and education. We're also very fortunate in our state to have as much data as we do, and it's a result of the hard work of our nursing leaders that have made all of this data available to advance our center's mission and goals. We rely very heavily on the Texas Board of Nursing's licensure files for our supply data on professional, vocational, advanced practice nurses. The licensure files include demographic data such as sex, race, and ethnicity, age, and entry-level nursing education, as well as the highest degree of a nurse. The files also include information on employment status and primary and secondary practice setting, position, and specialty. Additionally, residential addresses and practice addresses are also available. This data is very complete, and we have standardized fields that date back to about 2004, so we have several years' worth of data that we're able to work with. Our Workforce Center collects data from nurse employers, specifically hospitals, long-term care facilities, home health agencies, and governmental public health agencies. These data are collected through 4 separate surveys, and our response rates vary by setting. The surveys include fields on filled and vacant positions, separations, temporary positions, methods of interim staffing, recruitment and retention strategies, consequences of inadequate staffing, hiring practices, and transition to practice programs, among other things. So as you can imagine, they're very long surveys, and we get, our response rates vary by setting. We also collect nursing education data, and our center collaborates with the Texas Board of Nursing on their annual nursing education surveys that go to all professional, vocational, and graduate nurse education programs across the state. The surveys include questions related to student demographics, faculty demographics, enrollment, graduation, and admission numbers, as well as curriculum information, such as length of nursing curriculum, clinical hour requirements, advanced placement options, and program tracks. Besides the data that we get from the Texas Board of Nursing licensure files, all data is collected in-house with surveys developed in collaboration with our partners and administered online using an online survey software. And of course, in our state, there are other entities that also have nursing data, such as the Higher Education Coordinating Board, the Workforce Commission, among other state agencies and organizations. So why am I telling you about all the data we have? Because while we're fortunate enough to have a lot of data, we can answer a lot of questions, we still weren't able to tell people how many nurses we need now or in the future. We needed help pulling our data together to answer this central question of workforce planning. And of course, that's where the supply and demand models come in to help us. Our last projections on nurse supply and demand were published in 2005 or 2006, and they were based on the previous HRSA model. We didn't update these projections for 10 years due to a number of reasons, the most relevant being a lack of staff resources to dedicate to such a project, a lack of funding to contract it out, and because we were waiting for an updated model from HRSA. The long-awaited new numbers from HRSA were published in December of 2014, and in late 2015, we contracted with Tim's group to use the same model and to put Texas-level data in it for our projections. So going back to the 2014 report, like many states, we anxiously awaited this report to help support state-level efforts to strengthen the nursing workforce and to support findings from our center's projects. However, this report indicated that our state, like many others, would have a surplus of nurses by 2025. As you can imagine, this was alarming for many people, especially in states where there was evidence to suggest otherwise. So we reviewed the report and the technical documentation to learn as much as we could about the model. The reported surplus in Texas by 2025 was of roughly 6,000 nurses. When you have well over 200,000 nurses, that's less than 3%. So that was an important thing for us to consider. That's a very small percentage of our workforce, and that can be explained by errors in the model. Then we considered the underlying data on the supply side of the model, since that data, the number of nurses in our state, was a source that we could easily compare to. The American Community Survey was used to determine the number of nurses in each state for the underlying data needed to produce these projections, and this was one area where our actual numbers differed, and that could make a considerable impact on the projections for our state. So that's just one example of where we used our state-level data to begin our assessments of these projections. So when word was out that there would be a web-based model that would allow us to input state-level data, we definitely thought that would be a game changer. The web-based model became available in February of 2016, and at this point, our state-level projections and report weren't yet finalized, so we were very much interested in seeing the numbers produced by the web-based model and interested in comparing these projections to what we would get from Tim's group. So there are a few things that are great about the web-based model from my perspective. The best thing about the model is that it's available to everyone. Anyone can log onto the website and use it, and for those states with data, you can input your data into the supply side of the model. It's an easy tool to use, it's web-based, and it's free. So I think those are all great benefits for a model that HRSA could put out. However, there are also limitations we had to consider. As forecasting models go, they're analytical tools, and they use past behavior to predict future behavior. So we had to keep in mind that projections are best guesses. We also had to keep in mind that all models are based on assumptions. So we had to determine how the assumptions from this model fit our state's story. While you can input state-level data into the supply side of the web-based model, the inputs are limited to only a few fields of the model. And lastly, we considered that the underlying data sources had become dated, so our projections are based on numbers that were now a few years old. And these are all things we kept in mind as we assessed the numbers from the web-based model. So now I want to share with you our findings from the web-based model and compare them to projections from the Texas model. Those are the numbers we got from Tim, and our actual supply numbers for the last few years. I'm only talking about the supply side of the model and the supply projections produced. And as you can see, I'm only going to look at these numbers from 2012 through 2020. What you see in this table, there are 6 columns of data with projections that go out through 2020. The first column are the projections from the Texas model. The second column are the projections from the web-based model without our data in it. And then the third, fourth, and fifth columns are our projections from the web-based model with our state-level data input into the model for the years 2012, 2014, and 2015. The last column includes the actual Texas supply numbers from our licensure data for those years. Now, I've put this table up so you can see how the numbers differ with different years of state-level data, but I want us to focus on the next slide. This slide is limited to just 1 year of state-level data, and I'm focusing the data we input for 2012 since that's the most comparable to the Texas model. In this slide, you can see that the first year that we have numbers all the way across the table was 2014. The 2014 projection from the Texas model was within 2,300 nurses from our actual number of nurse FTEs in that year. The web-based model, without our state-level data input, was within 17,500 RN FTEs. The third column shows that the web-based model with our state-level data input into it was within 6,000 RN FTEs. Some of these numbers may seem large, but in Texas, these numbers aren't large at all. Let's look at the next table. Okay, and I've limited this table to just the last few years, the years that we have actual numbers to compare the projections to. As you can see, the Texas model, that's the HRSA model with the Texas level data input or validated against national sources. These projections are off from our actual numbers by just over 1% for the first few years. The projections from the HRSA web-based model with our state-level data put into the model were off by less than 4%. The difference increases in the projections from HRSA's web-based model that does not contain state-level data. The differences range from 7 to nearly 10%. A 3% difference. So comparing the projections from the web-based model to our actual numbers through 2016 yielded a difference averaging 3.2%. Even without state-level data, the web-based model's 10% difference in the numbers is still something we can explain and work with. You see the impact using state-level data makes in these projections and our ability to feel confident in using the numbers. So using state-level data in HRSA's web-based model produces numbers averaging 3.2% from our observed numbers through 2016. In our case, the web-based model produced numbers that we felt were fairly accurate. Of course, as we move further away from the baseline year, which is 2012, we would expect the difference in the numbers to increase as the projections become less accurate each year. If you go back to the first table, you'd see that the projections for 2020 from the Texas model and the web-based model with our state-level data put into it actually get closer to one another. I would expect to see both of these numbers be further from our observed numbers in 2020 as we get closer. You can also see how much further the projections from the web-based model are that do not include our state-level data and how much further they get from either projection with our data in it. So I think most of you are well aware of all the reasons state-level data is important, but in light of the web-based model and really any projection model, having state-level data will yield more accurate projections. That was certainly the case in our state. If you have state-level data, you can develop your own model, as some states have. It can also be compared to this model and others. It would also allow you to assess numbers, such as the projections or the sources used for the projections, to your state-level data to determine where they fall in comparison. And of course, I'm aware that not all states have data available to input into the model. You may have to still rely on what's available. And because the web-based model is an analytical tool and not meant to be target numbers, rely on what's available, keeping in mind how the model works, the assumptions it makes, and the sources it uses, as well as the limitations it presents. I think that if we can understand those things and educate our stakeholders on how to best interpret the numbers, this model, in particular, can still serve its purpose when it's all that we have. So that's all that I have. My contact information is on this last slide. So feel free to contact me if you have any questions related to our experience with this.
Thank you, Pam. If you could just hold on for a second, I have a couple of clarification questions.
Sure.
First of all, do you collect data from all your sources on an annual basis?
All of our supply data is collected through licensure, and that's collected from nurses every other year. So every year we have an updated file with nurses that may have renewed their license that year. So that's how the Board of Nursing does that. It's done on a rolling basis. And we take a snapshot of that data in September of each year. And then all of our employer data is collected every other year, but they were all collected on different years. So this year, 2017, we've combined our data collection efforts, and we'll be collecting all of our employer surveys at the same time, and moving forward, they will be collected every other year. And then our education data is collected every year in October.
Okay, thanks, Pam. One more question. This goes to a couple of your tables. Are you using the total number of licensed nurses or the total number of employed or active nurses?
The numbers that we put in, we're using the actively practicing nurses, and that's usually what we use to report on any number. It's just the nurses that have an active license who are working in nursing full-time or part-time at a Texas address.
Okay, thank you. That's all. And at this point in time, we'll go ahead and move on to our responders. And we're going to begin with Arpita Chattopadhyay of HRSA, and she has some updates on the web-based model.
Thank you, David, and thank you, Linda and Pam, for your feedback. You've provided useful input ever since the model was first made available, and we actually rely on users like you to improve the web interface, and the HRSA OIT folks are actually listening in on this webinar, taking notes to further improve the user experience. So we hope the next version that we are going to put out will be at least a better experience from the user's perspective. Folks have already actually gone over the rationale for developing a web-based model for nursing at the state level, but let me just sort of reiterate that. We recognize that considerable variation in nursing regulations and workforce policies really require estimates at the state level. At the federal level, we face some serious limitations in getting the best data and the best estimates. The states have access to a richer set of data and information may not be available to the federal government. At the federal level, we are working off mostly national data sources, and although some data sources like the ACS, on which the American Community Survey, on which the web-based model is based, have large enough samples that are representative of the state population, but their representativeness in terms of the nursing population may be somewhat questionable, and the availability of licensure files, which is essentially a census of all registered nurses in the states, is a great advantage. The states are also more tuned to their workforce policies and changes that may be imminent. For example, a state may be considering a policy of changing some licensure rules that may result in fewer nurses graduating in the future. They can use the web-based model, run the model, and get a sense of how it would impact their supply. And HRSA would not even be aware of the policy changes until after it was done. So basically, it's just to examine a bounce of ideas of policy changes, this model is an important tool. So while HRSA recognizes the need for a well-distributed workforce, the effects of maldistribution are really felt more acutely at the state level, and they also have the policy tools to remedy the situation. So we think that, it's always better for, local level planners to get access to tools like this. So that was the basic motivation behind developing this tool. It's really a laudable task, we think. There are challenges in projecting future workforce at the state level. First is, of course, Linda and Pam has mentioned, projections are based on the past. Now, at the state level, the past patterns may not be as stable as at the national level, just because it's a smaller geography and may be influenced by supply and demand interactions to a greater extent. For example, if there is excess supply, nurses can move out of a state. At the national level, that's more difficult. Or hospitals may reorganize if there is a shortage. So responses like these can impact the supply. That can impact the supply can take place at a fairly short time. So it's important that we have the stableness of the past patterns is kind of disturbed a bit. The other issue is that there is great variation between states in their ability to collect and organize data. For example, as Linda and Pam have shown, both Texas and South Carolina are pretty data savvy. However, not all states have that kind of resources. So there is a trade-off here. We want to provide the most functionality, but also to keep the model accessible to states which do not have a great deal of technical expertise. The other challenge is to users need to understand the results are not absolute numbers. They are variable depending upon the assumptions and the structure of the model. For example, there is a certain amount of uncertainty associated with the structure of the model itself, which is a microsimulation model, where outcomes are driven by probabilities and random number generation. Therefore, we recommend usually that the numbers be presented in thousands or some other large units so that it has some reliability. It has considerable reliability. In that context, I would say that the 3% error that Pam mentioned is quite reasonable, actually, and I'm happy to see that. Another assumption that impacts the interpretation of the results is the value of 1 FTE, which for the web-based model is fixed at the national level. What that would mean is that the results should be interpreted as what would happen if the nurses in the state worked at the level of the national average. And again, the point that giving the ability of to the states to tweak around with those kind of input is well taken, but again, hopefully we will get there at some point of time, but right now it's fixed. I did speak about the trade-off between, a more geographically disaggregated projections. However, I think that the input structure for the supply component of the web-based model allows for the sub-state analysis if desired, because there is an issue of labeling and, that kind of thing. But if one can sort of keep that in mind, there is nothing in the data system that when you are uploading the data that requires state-level data. You can easily input county-level data, and the only thing is you would need to keep track of it. But at the same time, we have to consider the stability of the results also. So currently, HRSA is upgrading the web interface so that it's more user-friendly. I must admit that we are not updating the data or any other aspect of the model, but what we are looking is to improve the user experience. We are trying to improve the processing time. The tabs and the options clearly emphasize that it's the supply model. Tim mentioned the demand model is basically fixed because the main function of the web-based model is supply side, and the demand part serves mostly as a comparison tool. We are complying with our OIT security team to ensure secure login. For this, we have included a robo-check in the login screen. We have organized the menu options and enhanced documentation with an About the Model screen, which will provide a short description of the model. So, just as you go in, even before you read the detailed technical document, you can get a sense of what the model is doing, what are its components, what are the data files that is using, and things like that. So a very basic background, but I would encourage all users to take a read of the technical documentation in detail before starting working on it. We have also introduced an announcement section so users will be able to know of any updates either to the model or the web design functionality. Finally, this is sort of a call to you all. We are planning to conduct user testing and hope some of you may volunteer. If you would like to volunteer, please email me or use the email link in the application, and we will invite you in a bulk invitation. So this is the next slide. This slide contains my email address, hrchattopadhyay@hrsa.gov, and if you want to volunteer, please do contact me or other assistant or the email in the web-based model. Thank you.
Thank you, Arpita. Tim, do you want to wrap up?
Sure. I'll just say a few comments before we open it up for questions. Thank you to all the panelists. They brought up a number of issues, and I just want to highlight a few of those. One is, over the past decade or so in particular, HRSA and the team that have been working on these models and the web-based model have really tried to be transparent through improved documentation about what the inputs are, the assumptions. And when we went back a decade and talked about how transparent should we be, the concern was, well, if we're transparent, it will invite criticism. But the response to that was, well, that criticism will help make the models better in the future. And so we do welcome that feedback, including feedback that might be negative, because that's the goal, is to make the models and the inputs better for everyone. Both Pam and Linda talked about several key things. One is the importance of using state-specific data. The preloaded data on supply came from the American Community Survey, and for some states, the sample sizes are fairly small. But even for the larger states like Texas and South Carolina, still there is quite a bit of variation between what the American Community Survey had for the starting supply of active nurses in those states versus what came out of the licensure file. So again, that just reiterates the importance of state-level data. Also, both Linda and Pam discussed the importance of being able to change all of the inputs and not just the basic information about the characteristics of the starting supply and being able to change a few parameters to run scenarios. I would note that since that model was developed and put online, that in the more recent, in the next report that HRSA will be putting out on the nurse workforce, it uses refinements to the retirement inputs, refinements to the hours worked inputs, refinements to the cross-state migration patterns. And so not only is it important in the models to have state-specific data, but also more recent data, getting back to a point that both Linda and Pam made. Arpita brought up several issues that weren't discussed by the earlier panelists, which was about demand. The focus of this version of the model was really on supply and the fact that the states had access to good supply data. But as we know, demand is just as important in supply if you want to make a comparison. and the demand projections also need to be updated to reflect newer trends, and also that, as Linda has indicated, that there can be significant differences between the states and national patterns in terms of healthcare use and delivery. So, for example, if we say in South Carolina that they need more nurses compared to their supply, but in South Carolina the hospitals aren't clamoring for more nurses, then the question becomes, well, is that because people in that state tend to use less healthcare services than their peers at the national level, or is it because staffing is different? So it does bring up a whole host of questions that hopefully can be addressed in the future, both in terms of customizing the model on the supply side, but also on the demand side. So I will leave it at that, and I think, David, we're now ready to open up for questions.
All right, thank you, Tim. Okay, the first question is really aimed at both Linda and Pam. So, well, here it is. According to the South Carolina and Texas numbers, ACS estimates are higher than the counts from the licensure files. Under the Nurse Compact, nurses from compact states can work in other states. For South Carolina and Texas, how are nurses registered in other compact states accounted for in the state licensure files?
This is Linda. I'll let Pam think about that for a minute. I think it's difficult. If in fact what you put into the online model for your state data is the number licensed in your state, it's a real problem because you can't account for those people who might have compact licenses but actually be working in the state. If, on the other hand, what you input into the model is the number of nurses that you know to be employed as nurses in your state, I think that helps a little bit, but not completely. What it does do is it gets you a little bit closer to what reality might be, but as long as you have nurses coming in and out that you can't capture in your state's data, it's a real problem. And I know at one time there was conversation about the National Council of State Boards of Nursing being able to track that, at least between compact states. But I have not yet seen any sort of reporting that would help states get a handle on that. Pam?
We can't account for that through our licensure data either. So, you know, we just see that as a limitation of the data source that we're using and, you know, chalk it up to the fact that these same other states are having the same issue. So looking at it from a national perspective, it's probably, you know, a wash, but I know at a state level it could make an impact. For us, we just have to deal with it being a limitation at this point.
Thank you, Pam, and thank you, Linda. The next question is really directed to, I believe, Arpita and Tim. Isn't the demand model pretty key as healthcare changes?
I'll let Arpita start on that one, then I'll follow up.
Okay. So actually, I mean, our models have shown that as healthcare changes, so primarily the insurance effect is quite small mostly in terms of the relative contribution to the change. The more important contribution actually comes from aging of the population, and for that we have a fairly clear projection on that. So I would think that, you know, any time, the further in time you get from the baseline, your accuracy might tend to decline, but it's not likely to impact very significantly in terms of the demand models that have been developed here. Tim, do you want to add to that or take off something if you want?
Yeah, I would agree that changing demographics is the key driver of changes in demand for healthcare services. And periodically, individual states and even at the national level, they update their projections. And so that is one change that needs to be incorporated into the demand models as those new population projections become available. But above and beyond that, there are significant changes taking place, as we're all aware. Some of those trends that are happening right now in terms of team-based care and the changing reimbursement models and so on. The verdict is still out in terms of what the implications might be on future demand. The demand projections currently in the web-based models are several years old, though. So HRSA does have a new report coming out that has more recent demand numbers, and that reflects a variety of updates. So I think that is one of the challenges with the web-based model, is the lack of ability to easily go in and update the demand projections and calibrate them to your state circumstances. That might be something that's addressed in the future.
Okay, thank you, Tim and Arpita. Next, I have a question from Jean Moore. She's the director of the New York Center for Health Workforce Studies, who happens to be right here with me. Jean?
What a coincidence. Actually, this question is for both Linda and Pam. So we've used the model in New York, and one of the things that struck us is the issue of regional versus statewide analyses. So in a state like New York, I think that urban issues, you know, the size of the urban areas, the number of nurses in urban areas, may drown out what's happening in the more rural areas of the state. So my question is, have you, either of you, done regional analyses, and have you seen the kind of variation that we think might be going on related to geography?
This is Pam, and I can start off with that. So with the projection numbers that we received from Tim, we were able to we have numbers that are regional, and we do see that variation. And, you know, Texas is a really large state with a very vast population and a lot of rural areas, and of course we do see that the shortage of nurses is much more pronounced in some of those areas.
This is Linda. We haven't spent a lot of time doing regional analyses yet. We're just now sort of getting into that. In South Carolina, we do have some very rural areas, but we also have some counties that have some metro aspects to them as well as rural. And honestly, we're kind of struggling right now to figure out who should be called rural and who should be called urban. We do see regional differences in the relative supply of nurses as well as the relative demand for nurses. And so in Charleston, we have, you know, an academic health center to the university, which trains all sorts of different kinds of healthcare personnel. It's a very heavy market demand area, and so that tends to throw off the whole state. Nothing looks like the Charleston coastal area. The rest of the state is very different. So I hear what you're saying, Jean, about really trying to get a handle on these regional differences. We're just now starting to address that and trying to look at what our pipeline appears to be for nursing production alongside those stats about both supply and demand.
Okay, thank you. I actually have two more questions I'd like to try and get to before we end today's webinar. The first one is, when will the new or updated HRSA report/model be published?
So right now we're actually working on, we're in the last phases of getting it edited, and some corrections are being made on the report. It has to, as you know, in the government, everything has to go through a clearance process, which might be quite time-consuming. So no fixed dates as yet, but soon we hope.
All right, thank you. And last question, and Tim, I believe this is really probably best answered by you. It confuses me when I enter our state data into the model. I put in 82,549 as the baseline 2013 data, and then the HRSA model estimates for the same year that the baseline is 72,816. If 2013 is the baseline year I enter, why doesn't the number remain constant? Can you explain this?
Yeah, I think I can, and I'm taking a guess here, but I'm pretty sure I know what's going on. So when we loaded data from the American Community Survey, it's loaded with data of people who are in the state, some of whom are active and some of whom are not active. And so it's applying labor force participation rates to get it from the number of people who are active down to estimates of full-time equivalents, and so those that are in the workforce and full-time equivalents. My guess is that the numbers that were put in were already cleaned up to be the active people, and so it's probably applying a labor force participation rate on top of that. And that was one of the challenges that we dealt with and really maybe hadn't given enough thought to until people started using the model, which is that some people are entering data that's already cleaned up of who's active, and other people might be entering data that includes people who are active, like have an active license, but might not be active in the workforce at that time. These are people that might, leave the workforce, bear raise children, and then come back in. So that is my guess of what's going on there.
This is Linda. I'd like to follow up with that because we ran into the same thing. When we first used the model, we entered the number that were active in the workforce, not realizing that what the model wanted was the total number with an active license. Two very different groups. It took us a while to figure out what was going on there. And I have to say, I think one important improvement in this model would be to let people declare what are they putting in. Are they putting in total number licensed, which then needs to be adjusted for workforce participation, or are they putting in the number who are actively participating and then only needs to be adjusted for FTE numbers?
Thank you. And with that said, I think we'll go ahead and end today's webinar. Thank you, Tim. Thank you, Linda, Pam, and Arpita for joining us today. I think you really provided some excellent information. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.